Recording in progress.
Thank you, Audrey. This recording will be posted on the Cost Board's webpage shortly after the meeting. TBW is also here today recording, and you'll be able to stream that live or view an archived version at a later time on TBW's website. We have a full agenda today, which can be found in the first tab of the meeting packet. And very exciting today, we have HCA's new director, Ryan Moran, who is also chairing the Healthcare Cost Transparency Board here with us today for his first meeting. And I'll hand it over to Director Moran to call the meeting to order.
Thank you, Ross, and welcome board members. I officially will call the January 28th meeting of the Healthcare Cost Transparency Board to order. I'm really excited to start the first conversation today as chair of the Healthcare Cost Transparency Board. I also want to thank especially Michelle Needham for serving as interim chair for a period of time in transition as we fully transitioned directors here at the agency. And Michelle, thanks for all the work and dedication to this work, even still going forward as well. I am looking forward to working with Michelle, Ross, and team on the priorities that have been outlined for 2026, and also thinking with the team in terms of all the changes that are happening in the healthcare environment. Where are some other continued areas of focus as we look at this particular work? This is obviously an important body of work, both nationally and here within the particular state, and new challenges that face us with a number of federal changes as well. So I'm looking forward to working with the team on that. So I am also wanting to, in this moment of transition, not just in terms of the new chair of the Healthcare Cost Transparency Board, but we also have some members who have moved on from their seats, and we also welcome some new members to their seats as part of this meeting today. So I want to thank some of the members that have moved on from their particular seats: Bianca Frogner, Greg Marchand, Mark Siegel, Margaret Stanley, Carol Wilms, and Edwin Wong. I want to thank them for their support and years of service to this particular work of addressing healthcare affordability and price transparency here in the state of Washington. And we also today, and I'm going to have the new members introduce themselves if they can come off camera. I don't see any of them in the room as of yet. There might be some coming in person, however, as I see here. But I just want to welcome two new appointed members from Governor Ferguson who would join us. First, I want to introduce Luther Hart Hodges. He will be taking the seat of Edwin as a member of our Cost Transparency Board, who's an actuary or an expertise in the world of healthcare economics. And so, Hart, I will pause and ask for you to say hello and introduce yourself and your background to the rest of the board. I don't see him on. Okay, maybe we'll come back to him. And then the second new board member who we welcome today is Emily Bryce. Emily Bryce serves as co-executive director at the Northwest Health Law Advocates, and she's a current member of our stakeholder advisory committee. So we know Emily well in our work across healthcare across the state of Washington. And Emily will be filling that role of representing consumers on the board, which is currently or has been held by Margaret Stanley. And we also heard from Emily at our November meeting, at the public hearing meeting. And again, of course, she is very familiar to the work in the advocacy community in Washington's healthcare space. So do we have Emily online for introduction?
I would just note that many of our board members do have a conflict today with the legislative committee. They are over testifying, so some of them will be joining us late today.
Okay, great. And I will just also take the liberty to say I have that same conflict. Here at 3:30, I have a legislative commitment that I will need to do, so I'll be stepping away, and Michelle will sort of take back the reins, if you will, as chair while I do that. And I apologize for that. In the future, we won't have legislative session at the next meetings, and we'll ensure that those will stick in terms of calendar moving forward. I just wanted to provide, as chair, a brief overview of today's agenda and this opportunity, I think, at this meeting at the start of the year to take a look back of what was focused on last year, and also start mapping out some of the goals and the objectives for potential priorities for the year ahead. And so the agenda will include a 2025 wrap up. Also at the November meeting, which I had the opportunity to briefly attend, That was the period where we had a public hearing and we had a debrief on the benchmark presentation and some of the themes that we heard from that meeting. So you'll hear some of those summarized from our team today. And then we will launch into Ross Wittes' discussions into 2026 areas of potential focus in our work plan. And then also part of our meeting discussion, and hopefully our colleagues will be able to join us from being out of legislative commitments at that point, but we also hear from the Office of Insurance Commissioner for updates, the Health Benefit Exchange, and the work in Mary Franzen with the Universal Healthcare Commission. Inclusive in our agenda is a brief break, and then we will be joined by Evan Klein, who will give us an update of what is happening on the Hill related to legislative updates and how those may intersect with the Cost Transparency Board work. And then the main topic of today, and thinking about area of focus for the future, continued area of focus for the future of being market oversight. And Ross will review that work and some national insights for that. So I will just note that stepping into the role of chair is an important opportunity for me, as I mentioned earlier, to think about the importance of this particular work and what is continuing. Even though we face a lot of challenges, we are not absolved of the responsibility in our state to think about what is driving healthcare costs in our state and identifying continued ways for improvement and affordability and transparency in our system. So I very much look forward to working with the board, working with staff, working with legislature, members of the community, and people who provide important input to this work to continue to try to achieve these goals, even in the times that we have. So with that, I will, Ross, I think I'm going to turn it to you, and you're going to do an official roll call for the folks who hopefully were able to join, even though I know we've got a lot missing for lunch commitments.
Thank you, Ryan. And just one note, I'm going to give you the opportunity to use the gavel. Would you be willing to call the meeting to order officially?
Yes, I will officially call the meeting to order.
Thank you. Okay, and I'll just note for the record, it is 2:08, January 28th, 2026, meeting of the Healthcare Cost Transparency Board. And thank you, Ryan, for that excellent opening. I will now take us to the review of meeting minutes. If you would turn to tab 2, Audrey, if you would. Oh, did I misroll? I am very sorry. I skipped ahead in my packet. My apologies. Folks, give me 1 second. I misnumbered my packet. Okay, my apologies. If you would turn to tab 1, Audrey. I'll now turn to roll call. Director Moran.
Present.
Thank you. Emily Bryce. And Emily noted that she would be late today. Hart Hodges. And looks like Hart is not able to join us today. Jane Byer. And I believe Jane is testifying. I'll see if Nico is here as the OIC delegate, Nico Jansen. Okay, not seeing anyone else.
Present. Nico Jansen for the OIC, present.
Thank you, Nico. Eileen Cody. Eileen Cody. Noting Eileen is absent. Lois Cook.
I'm here.
Thank you, Lois. Ken Gardner.
Here.
Thank you, Ken. Jody Joyce.
Here, thank you.
Ingrid is testifying currently. I believe the delegate is Leah Hold-Marshall.
Leah is here. Thank you.
Thank you, Leah. And Kim Wallace.
Yes, here.
Thank you, Kim. And we have 6 members present, sufficient for a quorum. So we'll now be able to move on to review of October meeting minutes.
Great. So thank you, Ross, for roll call, and I will move for a review and for a motion to approve the minutes. I'll just do a couple of reminders here. For the board, this is tab 2 that we're currently at. You're also posting the minutes on our screen. As a note, the recording of the last meetings are always posted on our webpage for reference or viewing for the broader public. And so with that, I will ask board members if there's any discussion of the October minutes, October 2025's minutes? And if not, can I have a motion for approval?
I'll make a motion to approve.
Thank you, Lois. And do I have a second?
Second.
All in favor, say aye.
Aye.
Are there any opposed? Motion's approved. The October cost board meetings are approved. And now I will hand it over to Ross. As I mentioned earlier in the meeting discussion, that meeting included, the previous meeting of the cost board did include a period of public comments. And I believe we're going to turn to tab 3 and Ross is going to review those results.
Thank you, Ryan. Now we will turn over to tab 3 with public comments. Written public comments received since the last meeting are available under the 3rd tab in board materials. We did not receive any written comments in advance. We also have not had anyone sign up in advance. If you did not sign up in advance and you'd like to provide public comment today, please raise your hand and we will call on you. You may need to accept a link as a panelist to be able to turn on your video and speak. When we call on you, please state your name and affiliation before beginning your comments. We'll also utilize a timer for 2 minutes for the length of public comments, so please be mindful of your time. And then we will listen to all public comments received during this time, but will not be responding to public comments in real time. And so with that, I will open it up to see if there's any hands raised that they would like to provide public comment. Okay, not seeing any hands. Oh, I see one hand. Katerina LaMarche with Wisha. Katerina, please accept the panelist link and go ahead and unmute yourself.
Hi, thanks so much. I actually just had a comment. It's really difficult to hear the folks in the room speaking. It sounds like the speakers are underwater. I don't know if there's any way to fix this, but just wanted to let you know there's some trouble understanding the folks speaking in the room.
Thank you, Katerina, for letting us know. These are the best speakers we have. So we'll do some thinking in the background, but please let us know if there's any improvement or decline in the quality of the audio, and we'll work on that. My apologies. Not seeing any other hands. We will close the public comment period. Thank you, folks, for well, thank you, Katerina, for your comment. And now we will transition to Michelle. I think you're gonna have to help me out. My script has.
Yeah, actually, I'm going to take it from here,
Thank
Ross,
you, Ryan.
and I'm going to tee up the next comment. So I'll do chair liberty. Is it just Ross, or can you hear me any better for folks who are online? No, it's sort of just the entire system. Okay.
It's everybody in the room.
Okay.
When they speak remotely over their computers, those are fine. It's just in the room.
Okay. Yeah, sounds like we have some support audiovisual who's on the way to try to check us out. So we'll do our best. I'm not sure that screaming in the room will even help. So I'm not sure what the solutions are. But thank you, Ross. And I'll just take a share liberty to say that was sort of a public comment period. Now we are going to move into the period where we do a wrap up and a debrief of 2025. So this was an opportunity, I think, to take a step back and look at the broader themes of what we heard at the previous morning meeting from cross-board members in the public, what we heard around the issues around affordability in Washington, and how that input will guide this board's work into 2026. I think Ross's summary of the presentation will make it clear that obviously we know this from the national conversation and dialogue that's taking place particularly around the sunset of the enhanced premium tax cuts, but the tax credits, but the healthcare affordability does continue to remain a pressing and personal issue for many Washington residents. So I think that Ross is going to walk through some of those key themes that we heard. And then we are going to open it up for discussion of what that means for our priorities and work plans in the future. And so, Ross, can I turn it over to you to guide us through the slides on tab 4?
Yes. And if you could go to the next slide, please. Thank you. So we are reviewing some of the information that we had collected over the year related to our cost growth against the benchmark. And this is some data that we thought was helpful to kind of show and explain the continued growth in healthcare costs over the last year. Growth in spending per member per year was the second highest since the board began collecting data. As we noted at the public hearing, all markets exceeded the benchmark, currently set at 3.2% growth per year. You can see in the chart on the right, we have a breakdown of the service categories in their percentage of growth within that growth from last year, which would be 2023 data to 2024 data. And so I apologize, 2022 to 2023 data. That's what those percentages are at the top, 7.3, 7.2. Similar to past years, the same drivers are leading cost growth, which is prescription drugs, professional services, and hospital outpatient. That's consistent with past years. And also when we look at other cost board states that track and collect this data, those seem to be the key drivers as well. So another year of seeing similar results and seeing cost growth continue to grow. If you could go to the next slide, Audrey. This slide is showing cumulative growth of commercial total medical expenses per member per year by service category. Non-claims and claims have grown the fastest in the commercial market. And you can see the table or the chart on the far right, where non-claims and claims other is demonstrated in the rate of growth. As we noted in the last slide, prescription drugs, hospital outpatient, professional specialty also grew very quickly. They've accounted for a large, and we can see the rate of growth in the middle chart over the past 5 years, 2019 to 2023, and the rate of growth for those specific service categories. And as noted, seeing the largest rate of growth with non-claims, followed closely by claims other and prescription drugs. And if you could go to the next slide. Thank you, Audrey. So the next steps after we had demonstrated or provided the cost growth against the benchmark presentation is to bring out our cost driver analysis, which we showed last year, and we worked with an external contractor on point. That goes a level deeper, more into the claims level, and hopefully will let us better understand those drivers that we just highlighted in any changes in terms of spending or anything that we might be able to propose a policy solution or application that may address that increase. We're hoping to bring the cost driver analysis to the cost board in our March meeting. That cost driver analysis, like I said, will dig a little bit deeper and also analyze price versus utilization for those service categories. It also includes some information related to behavioral health and primary care, prominent issues that we talk about here and are concerned about. So that's what we will be doing next. We are also going to be launching this year's data call here starting next month in February. So that process will continue in the background as we provide the cost driver analysis. And again, just for clarity, The data for the year that we were looking at was 2023. So when you're looking at that information, we refer to it as the 2025 data call, but it's reviewing data from 2023. And if you could go to the next slide. We also spent some time discussing or looking over the public comments that we received to see if we could find any themes. One of the themes that we saw was a theme of consumers noting that healthcare is unaffordable currently. We've included a variety of the comments that we received that kind of spoke to that point. I won't read through all of them, but it's something that we take great note of, as this is, our purpose is addressing healthcare unaffordability. And so hearing these comments and seeing the price growth through our data call really echoes the work that needs to be done and the challenges that all Washingtonians face regarding healthcare costs. Audrey, if you could transition. The next kind of batch of comments that we were able to kind of find a theme in was kind of from our industry representatives. And those were the main themes kind of coming out of that is trying to better understand what areas there is room for cuts and other areas where there's not room. We were reminded of different challenges that facilities face, such as different types of fees, staffing challenges, and being mindful of the thin margins that many healthcare facilities operate on. And similarly, some of the impacts that they'll experience with costs continuing to rise, such as impacting what services are available and more broadly access in the community. Audrey, could you transition to the next slide? Thank you. With this, we'll briefly cover one of our panels that we had. We had 3 panels at the public hearing. One of those panels, we heard from consumer and labor representatives. The consumer representatives covered survey data that reached out to Washingtonians to ask some questions about underinsurance and insurance on healthcare affordability. And again, the results that we highlighted here and not seeking care in some instances due to the costs. And that's with folks that are insured as well, because of the copays or deductibles that folks are facing. Another interesting one we did see was facility fees, in that those do bear, quite a cost on consumers, and we heard several comments related to that. We also heard that healthcare wages continue to be a struggle, both being able to afford highly trained, skilled workforce, and also managing the changes that come about when there's consolidations and mergers and affiliations. We know that typically comes with a change in the staffing ratios, and so heard some comments about that. Some recommendations we heard from our panelists about the unsustainability of the continuing increase in healthcare costs, as well as the importance of maintaining a cost growth benchmark and holding hospitals and healthcare facilities accountable to that cost growth benchmark, and wanting to make some progress, both in terms of having a healthy workforce and strong community, as well as putting some guardrails around market oversight and healthcare facility ownership, as well as kind of mergers, acquisitions, and transitions of healthcare facilities through different entities, and better understanding how those mergers and acquisitions impact Washington consumers, both on price and affordability, as well as access and quality. If you could transition to the next slide, Audrey. Thank you. Our next panel was the business panel. This panel covered a variety of topics, but I think one that really resonated with folks was the premium increase costs are unsustainable for employers as well. They're finding it a challenge to continue to afford benefit plans for their employees. And so also, seeing a real need, trickle-down effects that relate to less rich benefit packages that employers could offer, such as lack of retention for staff. There was a couple suggestions that were provided to us from the business panel, needing more primary care providers, greater transparency, and a recommendation to review individual coverage health reimbursement arrangements inside and outside the exchange. So appreciate those helpful information, and we'll continue to delve into these topics throughout the year. And if you could transition to the last panel. Thank you. Our last panel focused on insights from the payer and industry representatives related to healthcare affordability here in Washington. The healthcare stakeholders on board with addressing affordability in a large recognition that came up in all of the panels about needing to invest in primary care and seeing primary care and preventative care as almost a skeleton key to unlocking much of the affordability issues that folks face. The prevalence of mergers and acquisitions and impacts that has on patient access, quality, and affordability of care. Still seeing increased utilization post-pandemic, and I think our healthcare facilities are still adjusting to this new reality that we're in post-COVID, and needing to address that and needing to address the reciprocal cost growth that we've seen. And we did have a really good suggestion from this panel that the members would love us to focus more on bigger picture of affordability rather than focusing on, I believe an example used was facility fees, and trying to think of policy proposals that would address more systemic issues. So appreciated that comment. And again, wanted to just thank everyone that helped make the public hearing happen, and wanted to thank our panelists that participated. We thought it was really helpful. We had a ton of public comments. I believe we had 18 folks provide public comments. So again, just interest in this work. And Audrey, if you would go to the next slide. Ryan, yeah, if you want to.
Yeah, I'm happy to. Thank you, Ross. Is the sound got any better online? We have Jody's nodding yes. Okay, great. We have someone who's here working on it. Thank you so much. So it seems like we're in a better situation. Ross, thank you so much for the review of the period in the last meeting of what was covered and what was heard. And so now I think we want to open it up for a discussion amongst the board as a frame up to sort of the focus areas and efforts and potential focus areas and efforts for 2026 of the cost boards. To the rest of the board members for these discussions, these are sort of particular prompts. And we'll start with sort of the first two in the time period that we have together, which I will keep an eye on. We've got sort of 10 or 15 minutes for discussion around these topics. But just your thoughts on what stood out from the public hearings, and then how does this fit in or lead into the cost board's 2026 work plan? Oh, welcome, Eileen. Eileen's here with us. Thank you for being here, Eileen. So yeah, at this time, I will open it up for any comments from the board on maybe the first two questions. We'll take you 2 by 2. Yeah, Leah.
Appreciate the recap and the space that the Cost Transparency Board provides for gathering the different impacts and inputs. I guess it's not very surprising for many folks around this table that have been working in this space to hear those themes and to have some of them be contradictory. So I think in terms of the work plan, one thing we might consider is, are there some bright spots of best practices where we could invite or learn from places within each of those sectors where there is some progress made or some best practices that are moving them towards the benchmark that has been set, or towards addressing some of these larger problems. I think that might be really, and that might be an impossible task, but I think that might be really interesting to hear from folks that are able to implement some of the best practices that we have heard about, kind of generally speaking, or that come from different areas of our consultants or other experts.
Thanks, Leah. Just curious, any of the specific topic areas of those best practices stand out for you to dive in further in?
I think there is both, speaking about kind of the payer and provider groupings, some of our data shows there's broad variation, and there are some bright spots by certain entities that are making progress. And so maybe learning from them about what might be working or what they think is driving that success may be helpful as an example.
Thank you. Thanks for your comments. Other thoughts from members of the board?
I had heard recently from a friend who's married to a nurse, and they just left the state and moved to California, where she could make 3 times what she was making here. And, we are seeing wages increase here. And that's sort of, going to raise the costs as well. But I'm concerned that that might be an ongoing trend. Not everybody can just pick up and move, but people are expecting higher wages, higher and higher wages, and that's an issue I think that's going to continue to be an issue, a problem for us.
So I think you speak towards the sort of the underlying elements of impacts workforce, supply chain, other elements of facets that impact this work too. So thank you for that. Other comments from the board? I think, maybe just moving into the next two, folks sort of marinate on the first two, but obviously when the work was set out for 2025's cost board and the priorities, the healthcare priorities from the federal administration weren't yet known from the change in the election. So the world does look a lot differently today than it did even a year ago. And so as the board, you all, and the authority and our other state agencies think about sort of those dynamics and changes, what's the best way to incorporate that in those pulse of those impacts related to the broader impacts of HR1? And how does the cost board monitor sort of the inflection points of all of those different things that are happening and that we're already seeing playing out, from eligibility impacts across the system, commercial market dynamic shifts, the shifts in uninsured data, sort of the money that's in within the system? I know it's a really large question, but it's obviously something that's relevant, pertinent, that we as a board, as an agency need to think about. And so your thoughts there in terms of framing the 26 work plan.
One thought that I'm kind of really grappling with, don't really have an answer, but it's very distressing, of course. I'm looking to the virtual audience to see if you can hear me. Is my voice coming through? Oh, a little so.
I put the mic right at my.
Okay, I think is this any better like this? No.
It's still a little underwater, but we can understand you.
Okay, thank you. Well, my thought, my concern is that I
I noticed that in the public testimony, there was a summary, there was a bold bullet that said it's time for bold action. And it strikes me that it feels to me like the various parties and viewpoints that are all, sort of joining in this discussion are not, I feel like there's a missing kind of central point, and that is the sort of what moral obligation is it that we who are running the system have, to people who are suffering and are likely to have increased suffering, and even shortened lives uh, due to their inability to receive the care that they need. And so I just want to make a comment that, it feels sometimes that various people who are supposedly have, control and power and authority regarding the money and regarding policy, etc., are taking taking the stand that they are rather powerless and that they aren't. They wish that there was more they could do, but there isn't. That their costs are too onerous, supply, inputs too onerous, that the payers have their perspective is that they have, uh, margins are waning, and that, hospitals have certainly shared, data a lot from their perspective about what they can and can't control. And I guess I just want to make this statement that all the people who supposedly have all the power in the system, seem to be at a loss for, really being able to make change happen. And so I can also even say personally, I guess I could be even part of the problem. I haven't come up with a with a solution. But so I won't go on and on, but it strikes me that the conversations that they have happened at the cost board for quite some time and other policy gatherings, many of them, I hear us caring. I hear us wanting to try. I hear us wanting more data. I hear us, wanting to continue to work on this. But I do feel that we're in a mode of sort of not bold transformative action. I feel that we're in a mode of, doing the best we can. And that's it. So I'm concerned, so I just wanted to share that the feeling that I have about this is distressing. And here we are ostensibly being the movers and shakers and change agents, people with the power. And I feel it's concerning that we don't know that we feel that actually can make change happen. So I'm looking very much wanting us to find ways to take bold, transformative action. Thank you. Don't want us to continue to meet every few months, share our concerns and share our constraints and share about why we cannot make the change that we desperately desire. That's thank you for letting me share where my heart and my head, are right now.
Kim, I really appreciate your comments. Thank you for bringing it to the space and sort of the challenge of our introspection of the moment of folks with resources. So thank you for that. Other comments?
I'd kind of like to add on to that. Everything that I've seen, we've learned so much from so many people about where problems are in the system. And the major ones that I've seen are with the pharmacy benefit managers and the insurance companies. And I feel like we kind of butt up against, well, there's already a group that looks at pharmaceuticals and there's already an insurance office that handles that. But, we've heard things about 90% of a certain procedure is always approved. And it would really cut costs for the insurer if they would just automatically approve certain procedures like that. And I feel like we haven't been able to make recommendations for legislation on that kind of thing because of those other entities that are, supposedly working on it. But maybe those are the kinds of things that we should be looking more at.
Thanks, Lois. I will say, and I have also shared with our team too, the sort of the work around the prescription drug affordability work and that body sitting within the authority, how that work intersects. I understand historically getting reports out to this particular group, but I think that there's opportunity for us in the 26 plan as continued pharmaceutical costs and the work and how that impacts individuals across the state play a role. So I appreciate you raising that as well. I'm going to go to Jody Joyce.
Yeah, thank you. I just want to add on to the comments just made, and I actually think that all of us have opportunities to own this. I think there are some big pockets of opportunity, some of which have been named, but I think if not all of us see and own that each of us needs to do this hard work together, that we're going to keep pointing fingers somewhere else and not fully contemplate what we need to be doing ourselves. So somehow that shared ownership, and that, yeah, maybe there are a few big pockets, but each of us, I think, really needs to consistently interrogate our own contributions to what's driving costs and what's slowing costs across the state.
Thanks, Jody. Appreciate those comments too. I think about that a lot too, because I don't think any of us are absolved in this moment of just sort of, to Kim's point of thinking that there's just little that we can do. We aren't absolved from thinking about this challenge. I'd be interested in the board's thought about how to bring sort of those recommendations or those sort of shared facilitating ideas across those realms, because ultimately, we are not, and just to be, in the spirit of full transparency, typically within our own particular silos as an ecosystem, we're not always wanting to be clear around what are some of those drivers because of the impact that would have for us. So then we do get into that realm of finger pointing, if you will. So I'm interested in how to facilitate that through this board, or if there are other ideas that folks may have around that as well. And that kind of goes into sort of the future work of the pulse of HR1 too, because we are going to be in sort of a similar type of space without that kind of recognition.
Have we ever solicited from, like the people that come and do the comments to us regularly during public comment, like, from the hospital associations and those kind of places? Have we ever, asked what they think they could do and then shared that with the other people that are concerned, the hospitals and all of the other boards and such?
Yeah, that's a great question, Lois. Thank you. We get feedback from our associations like WISHA and WISMA regarding specific items that we discuss, but I'm not sure we've done it necessarily in that format. And I think too, what you're insinuating is a collaborative process as well. That would be us reaching out and trying to identify areas that of shared concern and see what, if anything, could be done to address that. So I think that's an excellent opportunity and perhaps could be a cross-board meeting where that information is highlighted and perhaps we can bring in some of those representatives as well.
Just note it may be an opportunity to use the steering committees as well, since all of the stakeholders are on our steering committee, and to turn some of that conversation to their generated ideas at the next meeting.
Yeah, I agree. Because the reality is, in absence of those ideas, or in absence of that particular call of how people want to contribute to being better at the system, then to the points that have been made, we have the appropriate levers and have the responsibility to take actions where it's needed. And so I think it's an excellent suggestion. So appreciate it. And Jody, thanks for bringing that to the room too. Other thoughts from members also on any additional commentary on how the feedback of what Ross reviewed would shape priorities for future advisory committees?
Well, in the spirit of the comment about a bigger picture, I guess the years I spent in public health are top of mind, and I guess I'm going to make a brief comment from that experience. And that is that what we're really, we're talking about all the concerns in the system, and clearly affordability and access to high quality medical care is of utmost importance. But ultimately, what we really all want is health. And we want better health, increased health status. And I think that, I'm not sure that we're marrying up what we understand about morbidity and mortality and what's actually what people are suffering from and dying from in Washington, marrying that up with the affordability work. You don't have to imagine very long or very hard that the effects, some of the effects, the things that we're fearing might be transpiring in our state over the coming months and years, is actually increased morbidity, mortality, people suffering, people who access medical care and people who do not. So I guess I do think that I believe that early on the work of the board, when we were first starting out, we talked about where is, what's the board's role and responsibility with respect to the health of people in Washington state, and sort of what health are we producing for all of this, the money that we are spending. And I think that we decided that it would be down the road, and that, the did we consciously chose not to take on that very big question about how to improve health status of people, of Washingtonians, and get more bang for the buck, get more health for what we're spending, for what we're paying. So I'm just wondering if now, a few years into this work, and given some of the extreme challenges that we're facing, that it might be time to figure out what do we know about the health status? What do we know about morbidity? How it's changing? Who's really suffering? Who is suffering more over the next year or two? And kind of marry that up with the affordability changes. So again, I'm not sure how we would weave that into the work of the board, but I know we care about health. I know we care about individuals, their health status, and their well-being. But that sometimes that can be lost in all the conversation about the health system and the money and who's paying and who's, all of that. So that's a wondering that I have.
Thanks, Kim. I'm also mindful of time, and maybe we have one more comment and then we move. Eileen? Yeah. Good to see you, Eileen.
Sorry, I was late. Uh, well, I don't know exactly what to say about this, having worked on affordability and healthcare access for 100 years, it seems like, and we don't seem to make that much progress. I would just say that I would hope that at some point we'll have a national answer to this problem because really each one of the states we keep trying and there are so many things that block us. And, compare the US to other countries and how they handle healthcare. There's just too damn much money in the whole system and everybody wants to make more of it. When we look at the fact that hospital CEOs and insurance CEOs are making millions, that's the US. And that's our basic problem in affordability is we want people to make a decent living. It's just what the definition of a decent living is and what's too much when it's affecting other people. And that's I think it's the healthcare system is just shows it so much more than some of our other areas. So now you've heard my frustration for the whole system.
Thank you, Eileen. Right. I am going to transition us to the next portion of our agenda. And I think now we've had a look back of 2025 in the previous meeting. We're going to now turn us towards a kickoff for the 2026 work, sort of this with what we just heard in mind, and what the board's focus will be in the future. So we're going to hear, I think, a brief update from the cost board's presentation that was provided in a work session to the Senate Health and Long-Term Care Committee, followed by an overview of the board's scope, priority areas, and our three-meeting work plan. While those presentations are happening, as I said at the top of the call, I unfortunately have to step out for legislative engagement, so I will hand the reins back to Michelle to take over as chair. And with that, I think I am turning it over to Rochelle and the rest of the cost board team.
Thank you, Ryan. And I will be substituting in for Rochelle today. She's a little under the weather. Thank you, Ryan. Good luck at your engagement as well. And also, just before I hop in, thank you so much, cost board members, for those comments. Really appreciate those. And that gives us a lot to chew on as we go over what we're contemplating for next year, but also what changes we need to think about in light of those comments and really hearing a sense of urgency. So thank you. Audrey, if you could bring us to the next slide. So I believe we've seen this graphic before, but this at a very high level is the different areas of focus for the cost board. As you can see, there's starting at the top, areas already impacted is one of the areas that we spent impacts, as other folks noted, as well as delivery system issues and other budgetary items as they arise. The green box addresses the current state of affordability. We look at that through our performance against the benchmark, cost growth and trends, and we also get a better understanding of that through our public comment and testimony that informs our approach. One of the other areas of focus of the cost board are strategies to improve. These are the proposals that we typically make to the legislature in our annual report related to cost containment strategies that are informed from the previous two circles that we went over. And so, as you notice, we view this as kind of a cyclical thing where each area of focus is informing the other. And as we just heard in those comments, strategies to improve seems to be an area that we'll want to focus on significantly this year. The next box, if we're going around counter, well, actually clockwise. Sorry about that. Is areas improving. I believe Leah from the Health Benefit Exchange had mentioned this in a comment, but also wanting to take note, Michelle and I recently presented to the legislature and wanted to make sure we were noting that as well. The percentage of Washingtonians that have health insurance coverage has grown significantly over the last decade. And so we have made strides, and I think it's important to recognize that and that folks are doing a lot of good work. So needing to focus on that, as well as other legislative achievements that have been passed that we're in the implementation process on. We spent a fair bit of time last year and hopefully this coming year discussing updates to the state health plan that OFM is working on, as well as provider registry work that the Department of Health is leading. So making sure that we're also investing time and energy into the implementation to make sure those align with the goals of the cost board. And then finally, areas at risk. These are those areas, items that haven't been necessarily impacted yet, but with additional changes or loss of funding, those could be at risk to federal changes. But we also know that there have been service line closures in local facilities that impact our local Washington populations and create other access issues. So always trying to keep those front of mind and kind of those more urgent priorities. And Audrey, if you could transition to the next slide. So turning towards our plan for 2026, we have three broad priorities, if you will, for 2026. That was informed by discussions with the cost board last year. And wanting to note as well, these are not set in stone. These are our current thinking, and it's very helpful for us to have a plan, but we want to stay flexible and nimble to respond to changes or to the interests of the cost board. So as we present this, I do want to make sure that reiterating the flexibility that we're hoping to carry with us throughout this year. The first issue area that we're going to be focusing on is market oversight, and more specifically impacts of consolidations, mergers, acquisitions in Washington for healthcare. So a couple of the areas that we're hoping to spend some time researching and then hopefully developing some policy recommendations or strategies are ownership transparency, better understanding who are the owners of our healthcare facilities, and when transactions occur, transaction review, hopefully enhancing our current transaction review that's primarily done by the Attorney General's office, the market or material change transactions, enhancing some of that. There's a number of bills this year and last year that are looking to do that we'll highlight and discuss further, as well as other regulatory actions that we can take, be more aware of our facilities that are operating in Washington, as well as making sure that we have a clear understanding of the quality and output of those. The next issue area that we want to focus on is price and utilization, with the goal that any strategies that we recommend would be towards slowing spending growth. Currently, and I think it was reiterated during the comments we just heard, our thinking was that we would focus on pharmacy spending, as that's been a top cost driver for, I believe, each year that we've done our data call. And so that would probably be our primary focus under the slow spending growth category. Would love any feedback that folks have of focusing on in that section. And then finally, primary care. As we've noted in our annual report and we discussed at the public hearing, we have a state spending growth goal of 12% for primary care as a percentage of total healthcare expenditures in Washington. Currently, we're about at 4%. I think we've all acknowledged, and it came up in the themes from our public hearing, that investment and more strategies to increase utilization of primary care is necessary. And so we plan to spend time thinking about those types of strategies and issues with the board. Generally, we would anticipate that each of these would take approximately 3 meetings, also including intervening months spent bringing issues and questions that the cost board has to our advisory committees, data issues, stakeholder, and primary care to inform those conversations and inform information that the board receives committees into each of these conversations based upon their specific specialties and expertise. So at a real high level, that is our 3 main topics for 2026. If you would move to the next slide, please, Audrey. This is a quick breakdown of our plan for the next few months. First, today's meeting, we're going to give a high-level overview of the market oversight topic, kind of identify a current state, some gaps that we've identified in terms of areas where we could enhance our market oversight regulation currently. We plan to we have a period at the end of today's meeting where we're going to hopefully get some input from cost board members about the types of questions that would be helpful related to market oversight to hear feedback on from our stakeholder advisory committee. We'll then, at our February Stakeholder Advisory Committee meeting, bring those questions that the committee did and hopefully supplement the information that we discuss at today's meeting with input from our Stakeholder Advisory Committee, bring that back to the cost board in March. And then at the March meeting, we're planning to spend some additional time highlighting market oversight strategies that have recently been implemented in other states, specifically California and Oregon, to kind of inform our approach, followed by a similar system of bringing questions that the cost board thinks would be helpful for the data issues advisory committee related to market oversight, and then bringing those questions to the data advisory committee in April, and discussing the market oversight issues with that body, and then bringing back any information learned there to the cost board in May. And then hopefully at that May meeting, doing kind of a reconciliation of the topics we've talked about, and hopefully developing some recommendations, or at least the beginnings of recommendations related to market oversight and transparency for the cost board. But thinking that would be good to start developing some of those recommendations early that we could work on throughout the year, hopefully to be included in our final annual report. And just to note, this is kind of documenting the market oversight pathway for the next few months. We would expect something similar for our other topics that we identified, slowing spending growth and primary care. So if folks have any thoughts or feedback regarding that, would love to hear that specifically as well. How we're integrating the advisory committees. It's been something that we've been working to try and improve how we're utilizing and ensuring that we're getting the great insights and expertise of our advisory committees and bringing that information back to the cost board. So if there are better, or if you're looking at this and see a way that we can improve the flow of information, please let us know. And Audrey, if you would go to the next slide, please. All right. The one other item I was just going to note real quickly is Michelle and I were fortunate to be able to provide a presentation on the Healthcare Cost Transparency Board's 2025 annual report and the 2025 cost growth against the benchmark analysis that we conducted to the House
Senate Health and Long-Term Care.
Senate Health and Long-Term Care Committee. Apologies. They all look pretty similar when you're sitting down there.
Interruption by the chair.
But joking aside, it was excellent opportunity for us to be able to bring the work that we're doing here to that body. There was definitely some questions related to primary care utilization. Again, that's informing our work plan for the year and wanting to spend some more time thinking about strategies to increase utilization. There were also some comments, again, related to pharmacy spending, and that will be another topic that we invest time in this year and hopefully develop some strategies to bring to the legislature through our. And with that, just wanted to provide a few minutes if anyone has any feedback or comments. I know I went through that work plan somewhat quickly, but if folks do have comments, would love to take them now. If they occur to you later, please feel free to email or call. We'll put our email in the chat for you. So if anyone has any comments, please feel free to raise your hand. Not seeing any hands. I think we will transition now to our agency report outs. Excellent. And I believe our first, well, let me give a little background, exactly what these are. This is something that we've done with our Universal Healthcare Commission. We've not as frequently done it here at the cost board, but in 2026, we want to make sure that we are sharing updates from our eight sister agencies. So these are brief updates that are important to inform our work as well as inform the work of other folks working in the healthcare landscape. Today, we're going to hear from Mary Franzen, who manages the Universal Healthcare Commission, and two of our board members, Jane Byer with the Office of the Insurance Commissioner, and Ingrid, if Ingrid is back. If not, I believe that we have her delegate Leah here with us. Each speaker will share some key developments, trends, or observations that may be relevant to our work. And so at this point, I'd like to hand it over to Mary Franzen with our Universal Healthcare Commission for a quick update.
Thank you, Ross. Good afternoon, everybody. I think this is the first time I've spoken about the commission at the cost board meeting, so I will give some very high-level background on it. The commission is a 15-member board, and it has a two-part charge from the legislature. One is to design the components of a universal system with a universal financing system, and the other is to look for interim solutions that can be implemented along the way to improve the system that we have now. And those components may or may not be worked into the final design elements, depends on the nature of that part of the work. So the work has been broken down into core components of what we need to build this universal system. There is a finance technical advisory committee that supports the commission's work. That is a 10-person committee. So right now we are dividing and conquering with some of the outstanding elements. So the Finance Technical Advisory Committee is working on provider reimbursement and on financing. And the Universal Healthcare Commission is taking on enrollment, infrastructure, and governance. So each of these pieces coming up with proposals somewhat separately. And then at the very end, we envision reconciling everything to make sure it all works as one cohesive package. As we go along, as these things are developed each year, we report to the legislature on the progress that we've made. So that's pretty much our 2026 plan. I hope to keep giving these updates. And if anyone has questions.
Thank you so much, Mary. And a really interesting part of the Universal Commission's work, part of their directive is to develop a proposal for a universal benefit design, but they also focus on transitional solutions aimed at containing cost growth before we're able to obtain universal care. And they spend a lot of time, they being the Universal Commission, thinking of those strategies. And we're hoping to Mary's point, highlight and complement that work that's being done at the Universal Commission with the cost, slowing down partnership this year. And thank you, Mary. And next, I will turn it to Jane.
Hello, and sorry for being late. The House Healthcare Committee hearing or was hearing the health benefit exchange request legislation. So we were there for that, and we are very hopeful that they will be, if they have not already, moving the preventive services legislation, which I'll talk about in a minute. So in terms of things that are most relevant to the Healthcare Cost Transparency Board, we had an opportunity for the interim to do a pretty deep dive on private equity activity in Washington State. And that report we sent to Ross, so hopefully it can be with the materials for the meeting. Just in terms of some highlights, back in December of 23, when we put out our preliminary affordability report, we said, we have information about what's going on nationally, but we don't have information about what's going on in Washington State. So we worked with PitchBook last year to get a better understanding of what is happening. And what are some of the key findings? The areas of greatest private equity activity: dental, musculoskeletal, vision, gastroenterology, veterinary, dermatology, and specialty pharmacy. And when you look across dental, vision, veterinary, dermatology, what you see there is sort of a theme of where there's opportunities because of a fair amount of consumer discretionary spending, i.e., what glasses do I get? Or what quality contact lenses do I get? And then also the other thing that you'll note is, for example, musculoskeletal and gastroenterology, those are heavily procedure-based. So ambulatory surgery center kinds of settings. From 2020 to 2024, there were anywhere between 74 and 111 PE deals in Washington State per year, with the cumulative deal values, annual cumulative deal values, ranging from $4 billion to $11 billion. And we provide information in the report about what we call the most acquisitive platform companies. A platform company will come into an area and they will serially acquire practices until they can have a dominant market position in any particular service. So we're always really interested in that, because the greater the concentration, the greater the opportunity to negotiate higher rates with payers. The other thing that we wanted to look at is, okay, people talk about PE acquisitions often sort of coming in and then going out in a relatively short period of time. And as of September of 2025, looking at the past several years of PE acquisitions in Washington State, we looked at the time between the buyout transaction, so when did PE come in and purchase the practice, and then the investor's subsequent exit. And of 58 PE-backed healthcare service companies in or affiliated with Washington State, 33 or over half were basically in it for less than 5 years. So the data here sort of bore out what we are seeing nationally. There is a bunch more data in the report, including in the appendix, some specific examples of platform companies and the Washington State entities that they've acquired. In terms of legislation and this session, you probably have all heard that the commissioner and the governor have requested legislation to preserve access to preventive services in Washington State. And we are happy to report that that bill is out of the Senate Healthcare Committee and in Senate rules. And as I indicated, it's hopefully coming out of the House Healthcare Committee as we speak. Commissioner Cooter continues to strongly support Senator Robinson's corporate practice of medicine bill. And then this session, in part, I think, with the information about private equity in Washington State, both Rep. Taylor and Senator Dingra have bills to expand the scope of pre-transaction review by the Attorney General's office to include non-healthcare entities. So that would give the AG's office the opportunity
to look at PE acquisitions and other non-healthcare entity acquisitions. I assume Ingrid or Leah will discuss the HBE's market curation bill. And then a number of you will see a variety of revenue-related bills this session, given the budget pickle that the state is in. And we've been providing technical assistance on those. In terms of what's on the horizon, probably the thing that we are most concerned about is every year the federal government puts out a rule that basically says, here are the rules of the road in the upcoming year for the individual market and the small group market under the Affordable Care Act. It is very late relative to previous years. Usually the proposed rule comes out like November-ish, December-ish. And based upon recent information that we obtained, we have asked when CMS anticipates putting the rule out, and they have said, we don't know. So, right, we are waiting for that. And we're especially sensitive to potential changes related to essential health benefits, defraying additional costs, different waivers, and there were a number of provisions, a market integrity rule that CMS put out earlier, many of which have been invalidated by federal court, and everybody's looking to see whether those provisions get moved forward into plan year 27. And then really quickly, in terms of ongoing projects, we just launched an obesity treatment study. So that's an actuarial analysis and including looking at cost offsets of obesity treatment due to the legislature in September. And then we have a report due to the legislature in October around what has happened with implementation of our ground ambulance balance billing rule, including what rates are being charged. And do have one outlier, and that is in Spokane County, where the rates are about twice as high as they are in other jurisdictions. So that's my report. Happy to take any questions.
Thank you so much, Jane. And for folks, the report that Jane was referring to is the last attachment in the cost board meeting packet. So if you access that online under our meetings and materials, you can find that. And just shouting out, it's a great report. It has a ton of graphics that help explain everything that Jane had noted. So thank you again, Jane. And unless there's any questions, I'll now hand it over to, not sure if Ingrid's with us. If not, Leah. Thank you, Leah.
Yep, Leah here. Thank you. Thanks so much. Leah Hole-Marshall, I'm General Counsel and Chief Strategist at the Exchange. I use she, her pronouns. Thanks for having me as your delegate today and providing a brief report out. I won't recover some of the ground that Jane laid out for us in terms of some of the bills that we're very hopeful for. I think to our earlier discussion today, I also have spent quite a bit of my professional life in the healthcare access and affordability space, and we're all still fully employed. So I know that feels frustrating, but I take a lot of hope in many of the things that you've heard about that we have been able to accomplish in Washington. And I think it's my personal belief is that it's going to be incremental. And so we have to look for incremental successes. So I'll focus a little bit on our commercial safety net, which is the individual market. And my component of it is the folks that are on the exchange. As many of you may have heard, the enhanced premium tax credits did expire, and the expected result was a lot fewer Washingtonians covered. Our open enrollment has concluded, so I'll give you a couple of updates about that. And then I really want to focus on what's coming up because we have had the first wave. And in HR1, which was one of the things that Ross, you mentioned about how we might maintain focus on that and how it might be impacting our affordability overall. There are lots more reductions coming, not only to the exchange program, but to Medicaid as well. So we ended our open enrollment with about 290,000 customers selecting coverage. This includes current customers as well as new customers. There are always folks that do not pay their premiums. So they've signed up, but they don't actually make that, what we call a binder payment. We expect that to be much larger this year once those first bills are coming due. There are grace periods, so we'll really know what open enrollment losses look like in March. But that's about a reduction that we were expecting from last year, but one that we have based on some of the innovative policy solutions that we were able to implement. Some of our customers experienced doubling or tripling of their premiums. Those that were hit the hardest were lawfully present immigrants and individuals at the very poorest, under 100% of the federal poverty level, as well as those that we consider higher income, which is around over 400%, which is $60,000 for an individual. So when I say higher income, I don't mean high income. I mean in our scale. They lost tax credits altogether. So they no longer qualify for any federal premium assistance. We had an average of $600 premium per month per person, which unmitigated would have resulted in an estimation of about 40,000 Washingtonians or 80,000 Washingtonians losing coverage. But because of some of the policy initiatives we implemented with assistance from the OIC and our carrier partners, that coverage drop is about 40,000 people. So I just want to take a moment to say it's very hard working every day here to know that we weren't able to fully offset the changes coming from the federal administration, and those people were very hard hit and are currently without insurance, most likely. Some may have other coverage. And I'm really proud of all the work that we did for those that we were able to benefit. So kudos to the OIC and to our team here, as well as working with carrier partners who also want to see people be able to afford and have access to coverage. The good news, I guess, is slightly offset by we are anxiously awaiting, as Jane said, the next rule from the federal administration. And we already know in statute, based on HR 1, that more changes are coming. And if they are not mitigated, we expect another 30% enrollment loss. So that's about 90,000 more Washingtonians without health coverage. So that will come through losing more subsidized insurance, enrollment barriers that we are required to erect. And without other changes, health insurance or insurers leaving counties because of concern about low enrollments. I think that we are looking for opportunities to build on the partnerships that we've already done. A specific example I would give you in terms of how we could build on this, and our bill, as Jane mentioned, is around safeguarding consumer access and affordability to make sure that the exchange has some additional authority to level the playing field in the market. We had a carrier exit San Juan, so we're down to one carrier in San Juan, and the one that remained is no longer offering bronze. Part of that reason is they don't have any assurance that they will not be the only one. And that's a significant risk to them. If we had authority to ensure that there is healthy competition, then we could create a condition where carriers would want to stay. And we accomplished that this last year in terms of reducing or eliminating tobacco rating. Most carriers in our market tobacco rated. For those individuals, they could have a premium that's $100 higher, for example, and not covered by any tax credit. When we talked to carriers individually, they said, we'd be happy to stop tobacco rating, but other carriers are tobacco rating, so we don't feel like we can make a change on our own. we were able to say you're not eligible any longer for state subsidy. If you want state funds, you're going to have to stop tobacco rating. And when we did that, all carriers stopped tobacco rating. So I think there are wins that that really have significant outcomes for customer premiums that we can look forward together. I know they're incremental, and I know it doesn't stop the overall losses that we're going to see, but I think it positions us well when we have a change. So we're working this year on ensuring that that state subsidy stays intact in a really tough budget year, which I understand there are many competing priorities, and the overall cost of healthcare is only increasing that pressure. And we're working on some incremental improvements that allow us to stabilize our market. That I'll hand it back to you and take any questions.
I'll just take a moment of personal privilege and say thank you, Leah, for your team and your work with the OIC. I know we have felt some coverage losses for certain in the marketplace, but Washington State's team really was proactive in planning ahead, be more creative than I have seen some of the other states. So their losses were bigger because your team was able to really plan options for us to mitigate some of that damage. So I just wanted to call that out for this board and recognize that publicly.
Thank you. I'll pass that on. They did really great work.
Please go ahead, Lois.
Being the one person on this board that doesn't have anything to do with healthcare, can you tell me more about tobacco rating? Does that mean they don't give a higher rate if people smoke, or they won't provide insurance to people that smoke?
Yeah, it's a higher rate.
Okay.
So almost all, when the Affordable Care Act passed, there was a recognition that insurers should rate in a community level, essentially, rather than at an individual level. And almost all other factors were eliminated by the ACA. So no rating based on pre-existing conditions, for example. This is one of the few that remained. There is extensive literature that shows that these are individuals that our society actually benefits from and lowers cost if you get them access to healthcare. And it was singling out individuals while the basis was that it's a personal choice, but we know that smoking is an addiction, and so singling out one addiction as requiring a higher barrier to health access when that's actually the services that they need has not shown to be successful. So again, that variation in a customer that might choose one carrier that tobacco rates at a very high level versus another just created more inequity in our system.
Okay, thank you.
Yeah, thanks for asking.
Great question, Lois. Thank you. Is there any other questions? And just a note, moving forward, we'll be surveying cost board members in advance of upcoming meetings to see if there's any report outs that members would like to share. So look for that for future meetings. Not seeing any hands up.
Ross, I do have one question.
Sorry,
I'm
go
just
ahead.
wondering, do we know, how will we know through the coming months, maybe year or two, about the impacts, access impacts, that are being felt at, FQHCs and other, safety net healthcare providers in Washington, and how prepared are they to step up, and what kind of supports are being imagined or are being put into place with that type of, the safety net provider?
Take a stab at that and say we'll have some updates on really what you're talking about are the impacts from HR1, and in particular the heavy impacts that we anticipate for our Medicaid program and our lower income enrollees and immigrant programs, as Leah mentioned. So there will be some updates. Certainly we have some materials that I expect will be publicly posted by next week that will also show some of the updated status on what the work we're doing within our Medicaid program here to develop some of those new requirements and really, I think, successfully mitigate some of that potential damage on people. So that is coming out next week, and I believe there's a public webinar that people can register for as well. February 26th, there will be a public webinar so that you can log into that and get an update on that material as well. So those will start showing up on our website, and we can make sure you have access to that web link, because I know our website can be hard to navigate sometimes unless you know exactly where things are. So we'll keep you apprised of some of that as we come along. And I think at that, we're ready for a break.
Yes.
5-minute breaks. We're back at 3:35, and we'll turn at that point to Evan Klein for a legislative update. So thank you very much.
Test, test. Test, test. Test.
Seems a little better.
How's that?
Sounds pretty good. Sounds pretty normal.
How is this come through?
Can you say a little bit more?
1, 2, 3. Testing 1, 2, 3.
That
That sounds better to me. So my husband and our business is phone service and conferencing and that kind of thing. And I just asked him what could likely be causing this, and he said there's a lot of bandwidth being used wherever you are currently, so it may not be something that can be fixed.
Yeah. Yeah, we heard that as an option or a potential issue as well. So
Yeah.
trying everything we can on our end. And
Yeah.
we'll just keep our fingers crossed for bandwidth.
You sound better right now, so let's cross them.
Thank you, Alice.
Oh, okay, so it is.
Apologies, folks. We are just working on improving our microphones. So we should be getting back here in just 1 minute. Apologies for the delay. Apologies again, folks, for that delay. We were just working on our microphones. Please continue to let us know if you're having any difficult hearing. But with that, we'll return from our break now. I'll hand it to Michelle to introduce our next speaker.
Great. Thank you, Ross. I will introduce Evan Fine, who's our Special Assistant for Legislative Affairs. He's going to give us a brief update on some of our legislative activity related to the cost burden.
Great. Thanks, Michelle, and good to see many of you this afternoon. A lot of familiar faces. I'm Evan Klein, Special Assistant for Legislative and Policy Affairs here at the Healthcare Authority. I hope that you can hear me okay. I don't know with these new mics if I should eat it or be backing away, but I will try my best. So I was asked to come provide a bit of an update on the agency, HCA's legislative engagement, particularly with the focus around some policies that we're working on or engaging on that may relate to the cost board. In years past, I've provided this same update and have largely focused on kind of themes for which HCA is approaching the state legislative session. Those themes have largely surrounded affordability, access, investments in the behavioral health space, coverage expansion, among other kind of critical policies. I think this year I wanted to frame things slightly differently in light of federal activity, which I would say is largely driving our work here at the Healthcare Authority, but also in light of some of the state budget considerations that I think are shaping what's happening up on the Hill here in Olympia, and tee it up kind of as four major questions as priorities in thinking about the intersections with HCA. So you heard a lot from Jane and Leah about some of the work that OIC and HBE are engaging on, and we are certainly engaging on much of the same. But we're really at this kind of close intersection between how the federal government's changes, particularly to the Medicaid program, are impacting Washington and having us rethink both about our programs, the program structures that we have, also investments in other spaces like coverage gap solutions. So I tee these questions up mostly for backdrop. How are we supporting necessary changes to state social service systems to comply with HR 1? For us, that's the Medicaid program, but it's also in conjunction with some of the work that's happening at the exchange and also DSHS related to the individual market, related to SNAP, TANF, other programs as well. How do we support populations that are going to lose coverage as a result of HR 1 or federal changes? So we're thinking a lot about those, as I would term them, kind of gap populations over the past couple of years. That's largely been a hyper focus on non-citizens who lack access to Medicaid. That's expanded in its purview this year because there are lawfully present non-citizens who are losing coverage from Medicaid in the individual market. And there are also individuals we anticipate who are going to lose access to coverage as a result of work requirements that are taking effect around ensuring access to sensitive healthcare services. So again, a focal point of the agency and the state over the past couple of years, but intensified this year with federal restrictions. So in the coverage space, how do we maintain access to things like gender affirming care and abortion services? And then can revenue be generated to support investments in healthcare where state funding is otherwise unavailable? So you're all probably keenly familiar with the state's budget conditions right now, and where in the past we've been able to talk about investments in access, we are having to refocus towards where investments are practical. And I say kind of the royal we here, the state. And so the agency does not have request legislation or specific policy priorities in this space, but we are engaged pretty heavily on a number of revenue related policies that I would taxes. There are about 5 policy proposals in from the state legislature that would levy new or increased taxes on health insurance coverage to then invest in things in the healthcare space. And it really brings up this proposition that we're frequently having to engage with, which is how do you pay for things in healthcare, and how does that work when you're having to generate that revenue from the healthcare sector as well? Because on one side of the ledger, we know that there are investments necessary and they're really critical for certain services like behavioral health services, or in the instance of a bill being sponsored by Senator Bateman, and abortion services. But then on the other side, how are you sensitive to some of the other factors that I know you all have been talking about related to increasing premium costs, particularly for the individual market and individuals who don't have employer-sponsored coverage? We are really focused on the budget, I think, as a result of a lot of that. We have a number of items that we're kind of being responsive to that were proposed in the governor's budget, Governor Ferguson's budget that was released in December. A couple that I want to highlight here because I think they are distinct and acutely relate to the cost board's work. One is just the contemplation of how we pay for prescription drugs in the Medicaid program. There is a movement of prescription drug spending from our Medicaid managed care program to Medicaid fee for service, which has some significant cost implications for the state. It relates to how we reimburse pharmacy in Medicaid in fee for service program. It's acquisition costs plus dispensing fees in Medicaid managed care. That can include a commercially negotiated reimbursed rate to the pharmacy, which is often higher than that acquisition cost. That means that there's increased reimbursement going to pharmacies and in some instances hospitals and FQHCs through that program today. And the state, I think, in remaining highly cost conscious in the state fiscal environment that we're in, is contemplating a movement of that to fee for service. It is a significant reduction in spending for the state, but also has downstream implications we're conscious of and working through. Another is around payment for facility services. I know this board has talked about facility fees in the past and site neutral payment as a policy proposal to adjust how payment occurs and where incentives occur for facility-based reimbursement, particularly clinical services that are being rendered at hospitals or through hospital-affiliated clinics on a more frequent basis. And so the state is contemplating a reduction in facility fees, moving I would say akin to a site neutral payment policy in the Medicaid program for we have been kind of supporting or providing technical assistance on in the background. We too are engaged on many of the bills that the Office of the Insurance Commissioner and the Exchange are engaged on related to coverage policy. Those include things like prior authorization and timeliness of claims payment. I think we are providing, again, technical assistance as an agency on those, acknowledging a lot of these relate to this proposition where there are financial incentives in all aspects of the market. And we've used certain regulatory policies or utilization management policies to try and control those costs over time. And there's a constant balancing act that the state is engaged with. And I think the legislature is becoming more acutely familiar with. And that's where we see, I think, an increase in the past couple of years of the legislature contemplating policies and regulation in like the prior authorization space or around claims adjudication, where that has largely been left to the parties involved, payers and providers. There's more, I would say, involvement of state and even federal regulators in that space. We're also engaged on 340B policy. There are some bills relating to that moving through the legislature this year, where the agency is engaged is mostly around any transparency initiatives that the legislature might be contemplating, again, providing technical assistance and talking back about how we do have programs here at the agency like the Cost Board, the Prescription Drug Affordability Board, and our Prescription Drug Price Transparency Program, where we do shed some light today on how pharmacy expenditure occurs in the system, but acknowledge there are some gaps in that understanding, particularly around 340B. And then I just want to highlight, we're continuing our implementation of Senate Bill 5083, which was passed last legislative session. And as a reminder, that is a reference pricing policy for our public and school employee benefits programs, where we are mirroring in large part a policy that was put in effect in Oregon that sets caps for hospital reimbursement for PEB and SEB and floors for primary care and behavioral health reimbursement. The proposition being, can we redistribute some spending towards higher value preventive services and generate some overall savings to the state that could be reinvested in other areas of our state budget by reducing overall healthcare expenditure, particularly for hospital services. Beyond that, there are a number of revenue-related bills that I kind of hinted at the outset. We're providing technical assistance on many of those. We as an agency tend not to weigh in on the merits of revenue policy, but we know that there is a lot in front of the legislature as they contemplate ways in which they might be able to invest in the delivery system in a tight fiscal climate. I'm happy to take any questions if there's time. Otherwise, I know you all know how to access me, and the Cost Board team can certainly get questions to me offline if I can be helpful, but just appreciate the time and the opportunity.
Thank you, Evan. Just watching to see if there's any hands or questions. I don't see any off the bat.
I do have one question. Do you anticipate changes, prior authorization, utilization review, et cetera, limitations, et cetera? Are there areas that are being targeted in particular?
Yeah, Ken, thank you for the question. So, and Jane can probably allude to this as well, but there are a couple areas, and the top line answer is yes. The focal point from our state legislature has been timeliness, kind of turnaround times of prior authorization reviews, and a focus on artificial intelligence. And we've seen this as a trend around the country, and including at the federal level, scrutiny about how health insurers might be utilizing AI to handle authorizations. So in front of our state legislature, it's Senate Bill 5395. It's a bill that was run by Senator Orwell starting last legislative session and didn't get across the finish line, but is coming back this year. The focus of that is thinking about what is the cadence by which a health insurer can update its prior authorization policies and notice requirements to providers, and when can artificial intelligence be utilized and when can't it be? And really the proposition there that I think the legislature is really getting at is people clinicians should be behind kind of formal denials of authorizations. If we're going to get to a place where someone is denied a service under their insurance benefit, that there should be a clinician that is participating in that decision, and that there isn't a algorithm solely making a prior authorization determination for an individual. We recognize there's a lot of bias that's being built into some of these large language models that could be impacting those decisions. And so I think we as an agency, as well as the Office of the Insurance Commissioner, have been working with hospitals and providers as we've kind of sorted out really technically how did those policies function. So there's a lot in the detail there, but I think that's in their focus. I do want to just note too, on the prior authorization side at the federal level, there's been a lot of focus on electronic prior authorizations and slowly migrating payers and providers towards the use of electronic and automated systems in that space. So there is some other in our systems as an agency to continue that migration towards EPA. And we know that payers, insurers are really working on those investments as well at the same time.
Really quick, that bill came out of the Senate Ways and Means Committee yesterday, so it's in Senate rules. The other component of that bill, we have currently some reporting on prior authorization that comes to the Office of the Insurance Commissioner for the commercial market. And there is significantly more reporting in the bill as it's proposed that OIC would add on, including the percentage of prior auth decisions that are in any way aided by AI. So that, and all of our reporting is public. So, and I can even point you to our current reports, Kim, if you want to look at them.
Thank you all. I am also noting in the chat, Leah is having a hard time hearing us, so we can speak closer to the microphones. Those soft voices in the room, like myself in particular. So we'll work at that. Thank you, Leah. Thank you, Evan, for the update. I would note we have an upcoming legislative cutoff date on February 4th for bills to be out of committee. And last day of session is March 12th at this point. So we will have more updates for this board at our next board meeting. So thank you all. I think we are ready to turn to our main overview topic for the afternoon. Ross is going to do an introduction into some market oversight activity.
Thank you, Michelle. And again, thank you, Evan, for that great update. As mentioned during the discussion of the 2026 work plan, today is our first day discussing the market oversight topic. And we wanted to provide a brief introduction, both the national landscape as well as to Washington landscape, an idea of the current laws related to market oversight, some potential gaps, and then review some of the topics and questions that we thought we could get some good feedback from the Stakeholder Advisory Committee, and then hopefully leave some time for discussion or questions. So without further ado, we can hop into our presentation. Thank you, Audrey, and I will hand it over to Jen to intro us.
Thank you, Russ. I'm Jen Scott, a health policy analyst supporting the cost board. And I think Ross thoroughly covered these first couple of slides earlier in the presentation. I'll just restate that today is an overview and that we plan to dig deeper into the topics over the next couple of meetings, focusing our March meeting on strategies that other states are using for market oversight and hearing from some guest speakers at that meeting. Next slide, please. And next slide. Market oversight is a topic which the cost board has had longstanding interest in. The 2024 and 2025 legislative reports contained multiple recommendations that fall into the bucket of market oversight. And some of them are listed here. You'll notice that several of the recommendations are about enhancing ownership transparency, including reporting, and also oversights for mergers and acquisitions and support for corporate practice of medicine law. Next slide, please. In December, Ross had the opportunity to attend the Peterson-Milbank Policy Roundtable, which was focused on market oversight and provided a lot of excellent information. Peterson-Milbank are a philanthropic, one organization or two organizations are philanthropic organizations that have been supporting the Washington State Cost Board work along with the 8 other cost board states. A portion of the slides that we'll present for this overview today are from that presentation, beginning with this one. The figure shows that consolidation in healthcare amassed through horizontal mergers, vertical consolidation, joint ventures, and contractual affiliation leads to market power, and that market power leads to higher prices for consumers. It can also lead to lower wages and even job loss for workers. Next slide, please. This graph shows national trend data in healthcare consolidation by a variety of markets. So it shows that 90% of hospital markets nationally are considered highly consolidated, 65% of specialty physician markets, 57% of insurer markets, and 39% of primary care markets. Next slide, please. This slide is also based on national data and shows trends in the ownership of physician practices over time. The blue line on the graph shows the proportion of physician practices that are owned by hospitals, and the red line is the proportion of practices owned by corporate entities. And then the black line at the top of the graph is the cumulative percentage of the other 2 lines that are on the graph. So the trend lines show that ownership by a hospital or corporate entity has increased by some percentage every year through 2023, which is the last year on the graph, moving up towards 60%. So another note from the slide is that 77.6% of physicians are employed by hospitals or corporate entities as of 2024. And now I'll turn things back to Ross, who will talk about consolidation in Washington State.
Thank you, Jen. Audrey, if you would move to the next slide, please. Thank you. So Jen provided some high-level and national context for market oversight. Wanted to give you some more information related to healthcare consolidation here in Washington. Washington has a moderately to highly concentrated health insurance market. We give some information there from the Herfindahl-Hirschman Index, HHI, that points to an uncompetitive health insurance market. Another area that we wanted to cover, again, just to give a brief insight into Washington, 54% of hospitals are affiliated with a multi-hospital system. 8 multi-hospital systems equate to 90% of licensed beds, 60% of staffed beds and employees, 65% of MDs and physician assistants who work in Washington hospitals. And as the report that there's been substantial growth in private equity over the last decade. If you would go to the next slide, please, Audrey. And so based upon that information and the cost board's interest in the past in this topic, we thought it would be a great topic for us to explore in 2026. But one area of importance for us is making sure that we're connecting our work on market oversight with affordability. And in kind of reaching that goal, one of the areas that we're currently inadequate in is our data on healthcare facilities and ownership and transparency. So that's one of the topics that we'll be talking about today and through the course of these meetings is that we do lack data on the current state of consolidation in PE in Washington. And with more data and information, we would have a better understanding not only of market trends, consolidation, but also how those impact prices and costs for healthcare. Another major area is ownership transparency. There's been funding for a provider registry to conduct a review and a report. The final report, again, that is just going to be recommendations related to a provider registry. But we believe, and other states who are working on this topic, think that having the provider registry, or in other words, database that is updated routinely with healthcare providers and healthcare facilities that are operating in the state is a foundational piece to developing these other market oversight and transparency tools. Just a very basic piece of information, knowing who is doing what and where in the state. But at this point, we don't have that, all of that information. We certainly have oversight over a number of healthcare facilities, but certain types, urgent cares, freestanding EDs, other types, we don't have that same level of information. And some of the work that we are going to be discussing is updating numbers, describing consolidation and private equity, enhanced capacity to look at information on market power via our APCD. Again, to be able to do that, we believe that the provider registry is market power with the information that we have in our APCD. Key driver analysis, getting back to identifying cost drivers and bringing in market power ownership into our key drivers for cost growth analysis. And then being able to incorporate historical data on costs and consolidation and do a actuarial analysis or study on that information. We think all of this would be the products of some of the recommendations or gaps that we currently have that we think could be filled with expanding the role of market oversight in the state. And if you would go to the next slide, please, Audrey. So as Jen had mentioned, I was able to attend a really good presentation on market oversight by Aaron Fusay-Brown, who is a professor at Brown University and works with the Center for Advancing Health Policy Through Research, or CAPER, and they do a ton of great work validation. So again, these are national, but I think they give a lot of good evidence of why states, us and the other 8 cost board states, are spending time looking into market oversight and transparency. So this slide speaks specifically towards the impacts related to costs. And so as you can see here, horizontal hospital consolidation prices increased 20 to 60%. So again, just establishing the connection between market oversight and affordability. We see here that as hospitals consolidate, prices increase. Vertical consolidation, so your hospitals purchasing a physician office and consolidating, raises prices 3.3 to 15.1% in physician prices, I should say 15.1% within 2 years of acquisition, and leads to 14.1% increase in physician prices. I won't go through all of these dot points, but I'm hoping that this does show that there is a next, cross-market hospital mergers. Cross-market is referring to a transaction that involves a merger acquisition between usually two entities that operate in different states and that are seeking to consolidate markets not only within a state but across state borders. We see with those transactions that the acquiring hospital prices increase 12.9 to 21.8%, depending on market conditions. And there's not a noticeable gain in quality, which we'll discuss in the next slide. Finally, PE acquisition impacts on costs. PE acquisition of hospitals lead to an 11% increase in negotiated prices, and PE acquisition of practices was associated with 11% increase in prices and higher spending than non-PE controlled practices. So again, these are giving some indication of the relationship between consolidation and costs. And Audrey, if you would move to the next slide, we'll discuss impacts of consolidation on quality. Hospital mergers, well, the top line here, mixed evidence of impact on quality. Hospital mergers did not affect patient outcomes, readmissions, or mortality, but patient satisfaction. So there wasn't necessarily a precipitous decline in quality, but there also was not a noticeable increase in quality. While on the last slide, we didn't show that there was an increase in costs. So you would hope to see a simultaneous increase in quality as well. The data is not showing that. Hospital ownership of physician practices led to higher readmission rates and no better quality measures. PE acquired hospitals, sorry, may have apologies if folks that are viewing remotely lost their screen there. And if we could go to the next slide, apologies, folks. If you're following along, we are on impact of corporatization and consolidation on quality. One slide back, if you would. P-acquired hospitals experienced 13.4% more deaths in emergency departments relative to non-acquired hospitals. And as Jane noted, an area where there's quite a bit of activity around PE acquisition is nursing homes. And they experienced 11% increase in ED visits, 9% increase in hospitalizations, 11% increase in mortality compared to non-PE controlled nursing homes. And then on the other end of the spectrum, in vitro fertilization success rates increased by 13.6% in fertility clinics after acquisition by larger fertility chains. So mixed evidence, I guess, if you will. But again, do you want to focus in on the impacts of hospital mergers, ownership, acquisitions, and no noticeable gain in quality measures while costs were rising? And if we could go to the next slide. Apologies, folks, having some technical issues here today. So the next slide discusses impact of PE ownership on workforce. Again, this one is specific to private equity impacts on workforce. So a little bit smaller discussion than in previous slides that were discussing impacts related to hospital conversions and acquisitions. PE-owned nursing homes have lower staffing levels and reduced LPN and certified nursing assistants. PE-acquired hospitals reduced staffing and salaries by 18.2% in emergency departments, ICUs, overall hospital FTE, PE-acquired hospitals. PE acquisition of physician practices resulted in physician turnover of 13%. As compared to non-PE controlled physician practices, and private equity acquired practices experienced higher physician turnover and marked increases in the number of advanced practice providers, the number of turnover of advanced practice providers such as nurse practitioners and physician's assistants, but not physicians, serving a higher volume of patients. And more on the qualitative side, there was a sample of internal medicine physicians, 57.7 viewed PE as negatively affecting physician well-being, and private equity employed physicians were less likely to report professional satisfaction, autonomy, and intention to stay. If we could go to the next slide.
Ross, can I ask a quick question?
Of course.
I was just wondering if there were data on the impacts on access. Consolidation and PE activity impacts on access.
It's something that I have looked for. I have not found a ton of data so far, and we can continue researching on that, but the direct impacts on access. But it is something that we've thought about in terms of there's a tendency, at least with private equity, to seek to consolidate, eliminate staff, look for reductions in spending, which we would think would be aligned with service line closures and those types of things. So we've been trying.
Efficiencies and, there are some areas, perhaps remote rural kind of areas where it's difficult to get the efficiencies, or scale that, they may be looking for. So anyway, yeah, thank you.
Yes, and so that's something that we hope to research further, but at least in my research, I was not able to find much academic research on that specific point. Yes, and if folks weren't able to hear, Jane was noting that service line closures would likely be a good indicator of those impacts, and we have some suggestions about that a little bit later. So again, wanting to kind of just ground us in this topic, we hear the term market oversight thrown around quite a bit. So wanting to just define what we mean when we're referring to market oversight as we're familiarizing ourselves with this topic. When we're mentioning market oversight, we're talking about state tools to monitor, review, and respond to healthcare market activity that could increase prices, reduce competition, and lower affordability or access for consumers. Market oversight focuses on structure and behavior of healthcare markets, not strictly prices, looking at trends in data to better understand long-term impacts of changes in the delivery system, changes in ownership and structure of healthcare providers. This is very common as well. Jane can speak to it far more in depth, but in the insurance marketplace, market oversight has a significant presence. And OIC does a ton of market oversight work on an annual basis. States use market oversight to better understand how consolidation and ownership changes affect healthcare costs over time. Next slide.
So Ross, just a thought. In terms, I was actually literally this morning just reading the Oregon annual report. And I think, at least in Oregon, and I think in some of the other states, market oversight isn't just about healthcare costs. It's about access, right? Quality. So hopefully we wouldn't be focusing in on just impact on costs.
It's a great point, Jane. It's something we've wrestled with internally, with our charge as the cost board and wanting to acknowledge, our directive, but also understanding those consequences as well. So
right, and I would think changes in quality, i.e., increased use of EDs because people can't access services they need outside of an ED, impacts cost. And then when it comes to things like service line changes, if somebody has to drive 4 hours to deliver their baby, the likelihood is there's going to be a higher risk pregnancy that we're talking about. So I think you can link those things back to costs. It might not be the price that's charged for a service, but cost impact, yes.
yes, yeah, and that is what we are hoping to do. And we're trying to kind of lay this out in a stepwise process to show how we're getting there. But we firmly agree that access and quality are closely linked to the outcomes related to consolidation and acquisitions. And just continuing kind of this introduction to this topic, just clarifying what market oversight is not when we're discussing it. It's not price setting. It's not a rate setting regime. It's not opposed to all forms of consolidation or consolidation in general, especially given the current budget concerns and economic state. We understand that consolidation is sometimes how facilities stay open, and that not all consolidation or more specifically, we're more focused on the "it is" section. Understanding and transparency related to those transactions, understanding who the ultimate owner is, what types of competition impacts a change in ownership or a consolidation would have, and as Jane noted, access and quality impacts. And finally, market oversight's not antitrust enforcement replacement. antitrust enforcement is currently managed by our Office of the Attorney General, and they review those transactions for anti-competitive concerns. That is not what market oversight is specifically looking at in terms of antitrust laws. This is looking at impacts to, again, affordability and hopefully, like we noted, access and quality, as well as provide of who's owning these facilities and making sure that it's clearly and prominently displayed. It is, again, early warning, transparency, and strategic intervention. I know in the insurance world, market oversight often assists in identifying insurers that are in financial distress and allows intervention. Not to say that that's necessarily where this would go, but that is a potential benefit of more clear understanding and transparency related to our healthcare facilities. Next slide, please. So hopefully those last few slides demonstrated at least the preliminary connection between market oversight and affordability, and just wanting to make sure we continue that with connecting it to our cost growth benchmarks here in Washington. Market oversight helps identify those drivers of cost growth. Some of those that we're not able to necessarily speak to now with our current data call that we would be able to incorporate into our understanding of what is impacting cost growth in Washington, incorporating impacts from consolidations, acquisition issues identified with mergers and acquisitions, preventing transactions that undermine affordability. That would be something like consolidation in a market that would leave no competitor, which we would assume would raise prices for consumers in that region. Those types of concerns. Enforcement of cost growth benchmarks. We think that this would be really helpful in our understanding and our setting of cost growth benchmarks, as we have a better understanding and transparency around the healthcare facilities and how the money is moving through those facilities into where. Increased transparency for policymakers and the public. This comes through in both the transparency or ownership transparency through items such as a provider registry, where the public and regulators can review ownership information for all health, as letting us know impacts on cost and affordability and quality and access through further research that can be done once that data becomes available. And next slide, please. So these are high-level strategies that some states have pursued to improve healthcare market oversight. This is to just give folks an idea of the types of work that other states have been doing to address the issues that we've been talking about here. First, oversee healthcare consolidation and corporatization. So that speaks to enhanced healthcare transaction oversight, as well as transparency and ownership. To address protecting the workforce and improving competition, traditional areas where states have invested is strengthening the corporate practice of medicine laws. As Evan noted, there is a corporate practice of medicine bill that's currently in the legislature. Washington currently does not have a corporate practice of medicine law. It exists through case law, so that would be one way. Restricting non-competes and banning anti-competitive provider-payer contract terms are other ways to ensure the workforce and competition is maintained. And finally, when looking to address cost and price growth in consolidated markets, a few of the strategies that states have pursued is site-neutral payment, restrict facility fees, and hospital price caps. So we'll move to the next slide, which will look a little bit more in terms of options that are available to us here in Washington. So the policy approach, again, thinking about healthcare transaction oversight. What we're trying to focus on here from a policy perspective is impacts from consolidation, impacts on costs, impacts or the frequency of closures as a result of mergers and acquisitions and sale leasebacks and other types of creative maneuvering that options for addressing the policy problem of transparency of ownership and control. The policy concerns that we should be thinking about as a cost board is the lack of accountability that results by not having those safeguards, if you will, or transparency tools available, as well as just a lack of clarity of who owns what and who is providing care. Strengthening the prohibition on corporate practice of medicine and restricting non-competes. The things that we can be thinking about here is the professional autonomy that our physicians and medical professionals have when working in the medical field. That, our hope is that medical professionals are the ones that are making medical decisions and not private equity or some other type of individual that may not have the patient's best interests in mind. So workforce effects, we had talked impacts related to private equity acquisition on workforce. So taking that into consideration. And then, as I had mentioned, interference with clinical decision making. When thinking about ways to address anti-competitive contract provisions, something to be thinking about, hospital use of market power and payer contracting. As hospitals consolidate and have more market power, there's less ability for payers to, exert more influence when negotiating contract and site neutral policies, facility fees, hospital payment caps. These are ways to address price increases that happen post consolidation. So I guess I would think of this as sort of the broad toolbox that we would have to be recommending policy approaches to the legislature as we work through this topic. So we'll come back to this slide periodically, but thought it was helpful to kind of see problems and things that we should be thinking about when trying to formulate solutions for these market oversight topics. If we go to the next slide, please. And apologies, I know there's a lot of text on this slide. This was an attempt to try and give a quick overview of the healthcare transaction oversight landscape in Washington currently, which is to say there is healthcare transaction oversight occurring in Washington. Just folks are familiar. First is actually a federal act, Hart-Scott-Rodino, antitrust. This, again, happens outside of the state. This is a federal process where the DOJ will review specific transactions to ensure that it doesn't result in monopolistic tendencies. Just a quick note, the 2025 transaction threshold to have your review done under the Rodino Act is $126.4 million for the transaction. So that just gives you an idea of the level of transaction that's being reviewed at that level. Smaller transactions are certainly not going to be involved in that. So now moving towards Washington's transaction oversight laws. We have the Consumer Protection Act, which looks at anti-competitive business practices, and that can be used as a means to help address anti-competitive tendencies that occur within healthcare transactions. It's not directly on point, but it is something that's theoretical anti-competitive transaction is being proposed to review and possibly prevent that from occurring if the state didn't have other transaction review policies in place. We also have most on point for healthcare transaction review is the healthcare material change transaction review that our Office of the Attorney General conducts. This requires healthcare market participants to provide notice in advance of a transaction. I believe it's 60 days in advance. for any merger, acquisition, or contracting affiliation between two or more hospitals, hospital systems, or provider organizations. Interesting caveat to that is that a transaction does not qualify as a material change if the covered entities previously had common ownership or a contracting affiliation. There's several other interesting caveats, but what I would note here is that this is a somewhat small pool of healthcare entities that would be included under the material change as current hospital systems and provider organizations. In your materials, this is a clickable link and it'll take you to the statute where you can see the defined term for provider organizations, but it is primarily speaking towards TPAs or third parties that assist with payment related to healthcare is who that is speaking to. So you can think of the number of facility types that would not be included in being required to submit notice of a material change. And then to just speak a little bit about the process, the entity would submit notice 60 days in advance of the transaction closing. If the Attorney General's office determined that that this was the type of transaction that requires the review, a review would be completed by the Attorney General's office. There's a number of criteria and factors that they look at to ensure that the transaction does meet the notice requirements. Those are provided, and the Attorney General's office is able to provide some conditions really ultimately. Next, we have certificate of need. This is a really limited type of transaction review. This only relates to merger, sale, or lease of an existing hospital. And that is no other facility types, just existing hospital. And important to note, the review criteria that's being used here is the certificate of need review criteria, which are listed here. Whether there's need for a new hospital, the financial feasibility of that hospital, whether within the first 2 years they'll be able to make a profit, cost containment that looks more specifically at impacts of that hospital in the local marketplace, whether there's competitor, the new or purchased hospital, and then quality of care. That looks historically at the assuming hospital to understand their quality scores. I believe those come from CMS. And all of those 4 conditions I just noted factor into the decision of whether a certificate of need would be issued to the assuming hospital. And finally, nonprofit hospital acquisition. This requires approval for nonprofit hospital acquisitions where the hospital is being acquired by a for-profit entity. This has not occurred in Washington for a number of years. There has not been a nonprofit hospital acquisition used, but it is a potential safeguard that exists in Washington. So I hope this demonstrates that there is existing laws in place to review healthcare transactions and some other laws that we use to look at other issues related to transactions like anti-competitive issues and acquisition of nonprofits. What we're hoping to lay out in these next few slides is some of the areas that we think could be expanded to better address some of the affordability and quality and access issues related to consolidation and acquisition. If we could go to the next slide, please. And this was, again, another slide to try and give an overview of kind of where we currently stand in Washington related to market oversight. And this is discussing the facilities that are currently subject to transaction oversight in Washington. And just one brief note, this is work that we did as staff to the commission. Happy to be corrected on any of this to make sure we've gotten the correct information, but that's not to say we can't miss anything. So if folks have any notes or if there's anything that we missed, we'd love to hear that feedback. So please reach out in that case. Turning back to the slide, Again, just highlighting Hart-Scott, that's going to be any facility type, not specific to healthcare facilities. Again, it's going to need the merger or the acquisition is going to need to exceed that $126 million figure. That figure is updated annually. Washington's Consumer Protection Act also applies to all facility types. Again, not specific to healthcare facilities, so it would apply to all healthcare facility types. The healthcare material change notice requirements, as I discussed, that's more specific. That is specific to hospitals, hospital systems, and provider organizations representing 7 or more providers and contracting with carriers or TPAs. As I noted, with certificate of need, just acute care and psychiatric hospitals, and again, nonprofit hospital acquisition that are nonprofit. So again, I think this slide demonstrates that we have some market oversight in place related to hospitals, hospital systems, and provider organizations or TPAs, less so for any other facility type. And there's not much in the way of transparency laws related to healthcare facilities. So we do have some laws in place related to oversight, but does not expand to many facility types. Yes.
Just a question. When all the references to market oversight and transparency, are we also going to give consideration to the additional step, i.e. that Oregon has related to approval or disapproval authority of potential transactions?
Yes. Yeah, we plan to go into probably more at the next meeting when we bring in Oregon and California to talk about the strategies that they've implemented, and some of them do have approval or disapproval authority over healthcare transactions. If they're required to submit it for prior notice, they do have the ability to place conditions or approve or disapprove those transactions, and talking about the pros and cons of that type of market oversight system.
Okay, and just one other thought. In generally, sort of, I've seen references to hospitals, physicians. When we're looking at vertical integration, the emergence of healthcare benefit management entities is 17,000 different varieties of services. And we also see insurers contracting with one healthcare benefit manager who subcontracts with another and another and another. And we've done some work to try to understand what's happening in terms of carrier submissions. And I think each of these entities, Linda Blumberg actually just did a great paper at the Center on Health Insurance Reform. And each of these entities is taking their piece of quote unquote savings that they're generating. And you have some revenue cycle management companies that are working for both insurance companies and providers, like telling the insurers, we're going to reduce your costs, and telling the providers, we're going to get you paid more, which is like a little bit not logical. So I think that we would be missing a big piece of what we should be looking at if we don't think beyond how we traditionally think about insurance companies and healthcare providers.
That's a fantastic point, Jane. Yeah, and that's part of the work of noting what facility types we currently have oversight over in terms of market transparency, and others we don't. But we have seen in recent legislation in other states that at least increasing transparency around those TPAs that are involved. I've heard there's difficulty in terms of the actual transaction review, because oftentimes those TPAs or project managers are not actually involved in any transaction. They're not purchasing necessarily, but they're and so at least as I understand it, transparency has been the recommended course of action to better understand their involvement at the very least, and then maybe more targeted strategies to. But That's kind of why we're trying to start at the beginning, because at some level we're lacking the transparency and knowledge of their involvement in the system, and we're trying to establish that and hopefully start there and then incrementally improve to hopefully get to the strategies to address their impacts on costs.
I agree. I'm a little bit nervous about, given the time frame for 1686 and the ultimate, right, a plan due to the legislature, and I can't remember what it is.
2028.
28, right? Is there work that can be done? So, we do the perfection is the enemy of the good, right? Is there work that can be done between now and then in the context of the board to try to get a better handle? I mean, for example, if there's PE involvement, PitchBook is a potential resource. So where can we get information on things without having to wait until 2028 to have the information, where there are options?
Yes, I completely, well, and I know OIC does regulation of healthcare benefit managers, which I think could be, yeah. Yes. So that, yes, we are thinking about those things, and to agree with your sentiment. I think Kim had mentioned this in the comments of not the sense of urgency that we have in 1686, which you referred to, which is that provider registry study bill. This would be very beneficial to have more transparency as we develop the requirements or suggested requirements for that. So thank you, Jane. And that's something we're going to hopefully address as we continue. Oh, go ahead, Emily.
Thank you. And I'll just say, glad to join this group, and sorry I was a little bit late today. I'll aim to be present for the whole meeting in the future. Just to add on to what Jane said, I think that's an important insight around the layers in carrier infrastructure, but we should also consider the layers in provider infrastructure as well, because we're used to thinking from reviewing and overseeing transactions involving something that we imagine in our mind to be a brick and mortar hospital, or perhaps a chain of hospitals. But when we think about hospital systems or provider systems, we are looking at the same layers of entities that are growing increasingly complex. And I think, as Jane noted, it's difficult to understand that. This is why transparency is needed. But just want to note that as we talk through the existing kinds of oversight that's available, that we're not getting below the surface of the particular provider facility.
Exactly. Thank you for calling that out. And Emily, I had intended to add an introduction for you at the end as we wrap up. That's all right. We'll add that back in, since we did start with that at the beginning of the meeting over at the legislature. So we'll come back to that, I promise. I just wanted to also note, for those of you who are not able to see the chat, Jody has a comment in the chat. Jody, would you like to go ahead and say that out loud?
Well, yeah, just adding to the comments being made here, that what we're seeing is this dramatic increase in vertical integration, right? And that's embedding opacity, it's embedding conflicts of interest, it's embedding drivers of costs, and it's teasing those things out. What you used to think of as a provider is now an insurer, and what you used to think of as an insurer is now your pharmacy benefit manager. And what and that is a phenomenon that it makes all of this more challenging, and I think ratchets up the sense of urgency around what we're going to do about this. So thank you.
Thank you, Jody. And Audrey, if you would take us to the next slide, please. Yes, and we will speed up. Apologies for my droning on here. Healthcare transaction oversight nationally. Again, speaking to what I was noting, that we do have some existing oversight, and especially as this table or graphic of the U.S. shows, Washington is on the more advanced end of having some approval authority for transactions involving hospitals, specifically the nonprofit hospital acquisition. Not necessarily the case for for-profit hospital acquisition, but we are, ahead of a majority of states and even having what we do have now. So, I've noticed Massachusetts, who tends to be the tip of the spear with healthcare regulation oversight, in the past 5 years has really developed their market oversight program. So again, this is a more recent investment in the healthcare marketplace as opposed to the insurance marketplace, where market oversight has traditionally been more prominent. And so going to the next slide, Audrey. I'm going to go over these pretty quickly. I think we highlighted some of this before. Again, just trying to support some of this data that we have about impacts on prices, on access, and on quality with some of the academic literature. Again, hospital mergers and consolidation contribute to higher prices and show limited or no impact on quality. And there's quite a bit of academic research on that point. Horizontal consolidation, which is consolidation between entities that offer the same or similar services, causes hospital prices to increase. Vertical integration, hospital acquiring physician practices, leads to price increases with limited or no quality improvements. Again, vertical consolidation between entities that offer different services along the same supply chain. So just reiterating that earlier point that mergers, consolidations do contribute to higher costs and show limited or no impact on quality. And Audrey, if you could go to the next slide. Same with market transparency. These are, again, speaking more towards those things like provider-incy into the ownership structures of our healthcare facilities. Some of the benefits of transparency regarding quality allows consumers to choose higher quality providers when quality information is publicly available. I'll acknowledge that the research does tend to show that consumers do not traditionally utilize a lot of the quality information that is out there, but research has shown that when there is, advertising and marketing that makes it abundantly clear that that information is available, consumers tend to utilize it, but they're not going to go looking for it necessarily. So again, that's a step for farther down the line. But as we are able to get more transparency, developing plans, and having a good approach to ensuring that consumers are able to access it and know it's there, I think is really important. Transparency regarding prices allows patients to choose lower priced options, especially combined with accessible data available before. Healthcare transparency tools are beneficial for consumers, but are underutilized due to difficulty understanding the information, accessibility issues, and lack of awareness around tools. So that's some of the benefits and some of the challenges related to transparency. And Audrey, if you could go to the next slide. Really quickly, as I know we're getting low on time here, these were, again, not formal recommendations by any means, but just some ideas. As we noted, Washington does have some market oversight laws in place. And just to reiterate that there are ways that, we think would be beneficial to expand. Noting Consumer Protection Act, asking applicants to demonstrate how the transaction would contain costs, maintain or improve quality or access for those related to healthcare transactions. We could see a huge beneficial effect in that. Related to healthcare material change notice, expansion of the types of facilities who are subject to that notice requirement. Again, similar, requiring entities demonstrate how it contain costs, improve quality and access. Currently, there's requirement that both parties to transactions need to be hospitals, hospital systems, or provider organizations. Changing that requirement to only one type entities, again, bringing more transparency to those. And then providing more transparency regarding the notice itself, so consumers are aware when these transactions are occurring, because they do impact their access in their community to these healthcare facilities and resources. We've seen transactions where, ultimately it leads to a service line closure or a facility closure. And consumers are often feeling like they are not provided sufficient notice and awareness regarding those changes. And then obviously an opportunity to develop new requirements, transparency requirements like we talked about with provider registries, establish advanced notice requirements for these entities when a facility closes or eliminates a service line, and establishing a healthcare provider registry, all areas that, we could look into to strengthen market oversight and transparency here in Washington. Audrey, would you advance? Thank you. Just briefly, again, we had gone over high level where we plan to go in the March meeting, and that we plan to bring this topic to our healthcare stakeholder advisory committee next month. And what we'll discuss on this next slide is some of the questions we were planning on bringing to the stakeholder advisory committee, and wanted to run those by the cost board and see if you have any suggestions and different types of questions we should be asking, or if these questions that we have will be helpful to you on this topic. Again, this is sort of a process improvement step for us as we are hoping to better utilize our advisory committees and really bringing them into the topics the cost board is discussing, engaging in, and trying to get their insights and expertise. So this is our first attempt at doing that, and appreciate any feedback or insights. And Audrey, if you go to the next slide. These are the questions related to market oversight that we were planning to bring to the stakeholder advisory committee. What types of healthcare transactions should be reviewed? What types of facilities should be subject to transaction review? Should healthcare transactions such as access, quality, equity? Should transaction review include conditions related to price increases, maintaining access, and/or quality outcomes? When referring to conditions, meaning that there would be an ongoing obligation on the facility subject to that transaction to meet whatever price increase rate, or maintaining current levels of access, those types of things post-transaction. And then what role should the public play in transaction review, whether it be a public hearing or better notice requirements and transparency? Was looking for feedback from the stakeholder committee on that. So wanted to open it up. Happy to take any questions on the market oversight topic, but would love if you have any feedback on these questions. Are we hitting the target in terms of getting the right type of information for you, the cost board members, from the stakeholder advisory committee on this topic, or are there different types of questions we should be asking? So we'll open that up.
So Ross, great work on all of this. Rather than saying what types of healthcare facilities should be subject to transaction review, what types of entities should be or healthcare facilities and healthcare related entities should be subject to transaction review? Because if we say healthcare facilities, then we lose acquisitions by PE investors who are not facilities, they're investing in facilities. And I think these are all definitely the right kinds of questions to ask. It's just the scope of what we're looking at. Emily, did you have thoughts?
I do have some thoughts. Thanks. Well, first, I just want to say thank you. I'm very supportive of the proposal to review our data and discussion together from a consolidation lens. I want to acknowledge that consolidation in and of itself is not necessarily harmful if it's paired with guardrails on affordability, accessibility, quality, and transparency, right? Absent those guardrails, then we have to take another look at whether we're able to understand the consolidation that's occurring in the system. So I want to kind of say that at the outset that consolidation may be something that is a trend that has benefit in our healthcare system, but we don't have the information to understand that at this point. And we would need to have those guardrails present. In terms of the particular questions for the stakeholder advisory committee, I'm curious to hear from different sectors of the advisory committee about their experiences with consolidation. And for the provider and carrier community, any best practices that they may have to remaining independent. I think sometimes in other arenas where we have less of an opportunity for dialogue, the discussion goes into corners quickly. And I think what we can acknowledge in our healthcare system is that there are many providers and facilities and carriers that are interested in remaining as independent as possible. And it would be helpful, I think, to hear from those that are succeeding or have had experiences that can provide information there. And then what kind of state support and engagement from the public might be helpful in remaining independent. Again, I think we can go into our corners and in the place of state oversight, and that is important, but also would appreciate hearing from the advisory committee about any ideas around what are some ways that the state can engage when an entity is considering consolidation in a productive way that will help that entity on the next steps in its path. So I hope to hear that from the provider and carrier community in particular. And then from the purchaser and consumer labor and also provider corner of the advisory committee, I would really like to hear more about any experiences that committee members have with consolidation. We have had lots of it in our state, and I think that we may have some individual experiences that people are able to share that can inform our next steps. Thanks.
Thank you so much, Emily. And really appreciate that point too, wanting to be careful not to demonize consolidations here, recognizing that market forces, currently are encouraging consolidation and acquisition. So wanting to be mindful of that as well. And I am not seeing any other hands currently.
Ross, I just have one idea. What about question for the stakeholder advisory committee? What about what would be reasonable to expect post-transaction in terms of like a measurable effect? What is it that, because lots of people are very enthused about, the opportunity and probably have information that they're envisioning perhaps some positive impacts on cost, quality, access, etc. And I would be very interested in understanding more about is there a way to set an expectation? Is there a way to say, like to Emily's point, well, consolidation in and of itself isn't wrong, bad, stop, but we need it to be better, control. So is there a way for us to envision knowing to track and measure that something is better, that first there's a commitment to achieving something better, and so that they're in a way a partner, the people who are after the consolidation, what is it they're willing to commit to, that actually, so we can all see that, hey, you know what? Thank you. You are a part of a robust, high quality healthcare system in Washington State. Thank you. I mean, that would be amazing, if that actually happened. So anyway, I guess from the advisory committee, I'm just curious, the promises or that are or the way that the opportunity and the benefits are spoken about. Is there a way to know whether that actually occurs?
That is
maybe they
excellent.
could meet the benchmark. I mean, maybe they could hit the 3.2%. I mean, that would be, beat the competition. I mean, I don't know, something along those lines. And that would be amazing. What if somebody came and said, hey, we've got a deal for you, Washington, and, you can measure this.
Thank you for raising post-transaction compliance and monitoring. I think that's a huge issue. When I was with the Certificate of Need program, that is always a really costly and difficult thing to maintain, and requires a huge commitment in resources to follow that in an ongoing nature. But to your point, if you're just reviewing pre-transaction, you have no idea how it's actually functioning in the market. So point well taken. Thank you, Kim. And I think that will wrap it up. Thank you so much. Well, first for listening to me droning on. I hope you could hear sufficiently. And thank you for your comments. Greatly appreciated. Again, go ahead.
Add one more thing. This comment is a bit misplaced because I was just coming in as you're reviewing the 2026 work plan. So I may not have heard it, but going back to the 2026 work plan for a moment. I'm wondering, thinking about Leah's marks about the folks who are losing coverage now and facing affordability coverage now and the urgency of the challenges there. If there's a possibility to build in, if it's not already built into the 2026 works plan, opportunities for the board to check in on consumer experience. And when I say consumer experience, I mean individuals and other purchasers, market sectors, how that is going from an affordability perspective, and any trends, a report back from, maybe able to hear from the exchange about their market segment. I know under House Bill 1508, we originally had an underinsurance survey and an employer trend survey. And I think it would be helpful as we continue in the discussion to make sure we have some time to come back to the few data sources that are available to us. For example, looking at MEPS data or KFF data or any BRFIS data, whatever we may have, to understand how folks are doing, because this work that we're talking about here is very important and also slow, and people are struggling now.
Yes, thank you, Emily. That is something that we can definitely work to incorporate in, and do plan to hopefully feature some of the you had brought the survey results to the panel, and hoping to highlight those as well. So thank you, Emily.
Thank you, Ross, for the thorough introduction to the market oversight topics that the board will spend a couple of more months examining. I think that was a really helpful foundation for the board to get an introduction and obviously spark some interest. So that's really great to lay that foundation. Before we do a complete wrap up of the meeting, I do want to go back to the beginning of the meeting and recognize we have a new board member who was able to join us today. And thank you for already contributing actively. Emily Bryce, would you like to take a moment to introduce yourself?
Sure. Thank you for the opportunity to be here. It's an honor to join this board's work, and maybe I'll just leave it there.
Okay, I'll just note Emily is serving as the consumer representative and is from the Northwest Health Law Advocates. So she will be an active voice and has been an active voice in our work to date with the board. So we appreciate your energy and commitment. Thank you. Likewise, we appreciate all of the board members' energy and commitment and willingness to continue on this journey, examining affordability options, thinking broadly about how we impact our opportunities in front of us to protect our residents of this state. So thank you for signing up for the continuing conversations. And I think next month, our next meeting is in March 25th from 2 to 5. As Ross noted, we'll continue some of this market oversight conversation, probably have a brief legislative update. We have some guests already lined up to come and talk about specific components of this market oversight that were identified. We'll hopefully have a report out from the Stakeholder Advisory Committee meeting that is in February. And then we'll continue to refine our 2026 work plan as well. So thank you all very much. And let's see, I'm supposed to note the recording and the summary of the meeting will be posted website shortly. And I think with that, we can adjourn. So thank you very much. Gavel out.
Thank you all.